So Dupuytren's disease, it's also called Dupuytren's contracture. It's a benign, non-cancerous thickening of the connective tissue, or the tissue that lies between the skin and the tendons in your hand, in the palm and the fingers. It can start as a little tiny lump or a nodule on the palm. Sometimes it's mistaken for a blister or a callus. And it's important to know that this condition is progressive. So eventually you get string-like cords that develop beneath the skin going into your finger. And if it progresses, the fingers are then pulled down towards the palm and they cannot be straightened anymore. And this results in the condition called Dupuytren's contracture. It's associated with other related conditions like Lederhost disease, where you can get the thickening on the soles of your feet. Very rarely, but it does happen. In men, you can get it on the penis, where it appears as a plaque and causes the penis to curve upwards. It's named after a French surgeon, Guillaume Dupuytren, who described the condition first in 1834. So in essence, this can appear as nodules in the palm. It can occur as small pits or small holes in your palm. It can then appear as contractures with cords that go into your fingers. And sometimes you can get it over these knuckles, what we call the PIP joint, or these knuckles. You can get dorsal thickenings that sort of look like little felt pad cushions that are not meant to be there. And these are all the various small things that can present in the early stages of Dupuytren's disease. So in most cases, there's a family history, and it can sometimes, however, miss generations. So there's a genetic component, and there's also environmental factors that can contribute. So in the genetic side, it's described as autosomal dominant, which means that the gene needs to be present in only one parent for you to get the condition. Not everyone gets it, and it can miss generations, and this is not clearly understood. It's seen more in males more early, but as you grow older, the risk difference between males and females come to sort of equal. It's usually seen at about the 40-ish age group, more common in Caucasians and with North European ethnicity, but it's also common in other ethnicities. You can see them in Asians, Africans, and there are certain factors that are considered to be associations, not necessarily causal, but associated with Dupuytren's. Excessive alcohol consumption, heavy smoking, diabetes, hypertension, raised cholesterol, some types of epileptic medication, and hand injuries or trauma, or more recently, there's been suggestions of use of vibration tools and vigorous physical activities with the hand can cause or trigger Dupuytren's to occur. So in the early stages, Dupuytren's disease can be well managed non-operatively and does not need any surgical input. It's often important to see a hand surgeon to confirm that the condition you have is definitely Dupuytren's disease. It does take a few minutes to examine you, and that will give you a really good reassurance that this is nothing sinister, nothing to worry about, and this is Dupuytren's disease. I wouldn't leave it till late, but an initial assessment is usually useful. There are a variety of websites available on the internet that provide useful information. One is the Dupuytren's Society, which is a British website which has excellent information on the disease itself and the treatment options. And the American one is called dupuytrens.org. And the British Hand Society also has a very small subsection explaining the disease further. So initial stages, when you've been diagnosed with the condition by a hand surgeon, As long as you can get your hand flat on a table and it doesn't bend upwards, you can manage it non-operatively, monitor it, recheck it every few months to say that it hasn't progressed. In a very small proportion of patients, this can become painful. It usually means that the condition's proliferating or it's growing a little. And I would strongly advise using topical anti-inflammatory gels, glove pads, and coverings when you're holding or lifting objects. There are a few non-operative options that have been described, but not all have been proven to be effective with randomized controlled trials. Shockwave treatment can provide symptomatic relief. Radiotherapy in the initial stages, where you have radiotherapy for 5 days, break for a few weeks, and then reapply it again, can help reduce the symptoms. But you have to bear in mind everything comes with risk and benefits. There's a risk of early desquamation or redness and scaling of your skin. Very, very small risk of the risk of radiotherapy affecting your normal tissues. And as mentioned, there are 1 or 2 or 3 centers in the UK that are offering it with good early results, but it's not, as far as the literature suggests, useful in the late stages. Surgical treatment, there are a variety of options available. The simplest option is to consider what's called a needle aponeurotomy, which is you use a small needle to inject some local anesthetic into the area, and the needle itself is then used to gently cut the cord and stretch the finger. The advantage with this treatment is that you can start using your hands as normal the next day. It doesn't involve a lot of time off work, but again, it's useful only when the early stages where the fingers just started to contract. It does, however, have a recurrence rate of about 80% in about 3 to 5 years. The next step up is simple open surgery to remove the diseased cord and close up the skin. This is slightly more extensive than the needle aponeurotomy. You need to rest the hand for about 2 weeks, wait for the wounds to heal up, and then start gentle activities, but I would avoid any heavy lifting for about 6 weeks to allow the tissues to recover. And bear in mind all of this, it'll be helpful to have hand therapy post-surgery to help you with your function. You may need some nighttime splinting in the early phase, only at night. Lastly, there's an option called dermofasciectomy and skin graft, where you excise the diseased tissue, which may be needed if the skin's contracted too tight. So when you stretch it out, there will be a skin loss and that will need to be covered. Or alternatively, in people or males who have it in, or women who have it in multiple sites where the risk, and a strong family history, where the risk of recurrence is likely to be higher. The excision of that area of skin, and I usually take a skin graft from the upper arm on the inside, the use of that skin graft to that area can decrease the recurrence rates to about 10%. Even with the limited or open fasciectomy without the skin graft, the recurrence rate decreases, but only to about 30%. So I do reserve the skin grafting option for those conditions where it's more severe or have a strong family history. Those are the variety of options. In summary, in the early stages, do nothing. If you've got early disease that's causing your finger to contract, you may be suitable for a needle aponeurotomy, or in the later stages, you may need open surgery in the form of a limited fasciectomy or excision of the skin and skin graft from your upper arm. That covers most of the non-surgical and surgical options. Collagenase was an enzyme that was used to dissolve the cord and then stretch it out. Needle aponeurotomy has shown to have the same efficacy as collagenase, and the company that manufactures collagenase has withdrawn it from the UK, so this is no longer available in this country. So again, in the early stages, when you get just the nodules, it does not significantly affect hand function, but if you're sitting around and trying to stretch your fingers backwards, you might find that it gets a bit tight, or you find that everything's pulling a little in the area of the nodule. But doing day-to-day activities, it should not really affect you to any degree. Very small cases when it proliferates, as discussed previously, when it's trying to grow or expand, it can produce pain. It settles over a period of a few weeks once that proliferative phase settles. But again, if it's painful, then you can seek advice for further management. Now, other things people complain about is when you're washing your face, if you've got a finger that's bent, you're likely to have problems with the finger knocking. People find it difficult shaking hands if one of the fingers is slightly bent. Putting your hand into your pocket might sometimes be difficult. Getting money out of a purse might be difficult. But there are a lot of options available. There are devices that the physiotherapist or the hand therapist can direct you towards. You can use modified silicone grip devices when you're holding things. You can use an electrical scissor if you're needing to cut and you can't get your finger into the holder. There are various websites and companies out there. One of them, PETA UK, which provide modified tools that you can use for around the house and outside, and it's worthwhile to have a look at those sites as well. With surgery, if you're having a needle up in your otomy, you're back to activities the next day. With open surgery, you need to keep your hand dry for 2 weeks, and waterproof covers from companies like Limbo can help you get in and out of the shower during this period. And post-surgery, you may have some altered sensation along the digit for a little while, and the hand therapist can help you post-surgery to regain range of movement of your hand, at the same time protecting the scar tissue from further damage if you do any heavy lifting. So I would avoid any heavy lifting for the first 6 weeks. You may need a night splinch for a few months after the surgery, but only during nighttime, and you can get it moving in the interim. With all this, you need to be clear that none of the treatment options are curative and there's always a risk of recurrence, but we can manage them as and when they do arise.